My name is Patrick Farley. I work at the University of Mississippi Medical Center. This is part 6 of the discussion of CTA. We're going to talk about CT perfusion in stroke. The point of CT perfusion is to figure out the penumbra, or the area of brain that could be salvaged with thrombolysis or clot retrieval, and differentiating that from parts of the brain that have been irrevocably damaged to go on to infarct. That's the infarct core. So why not do an MRI? The MRI is going to be more sensitive in the early parenchymal changes of infarct. However, it takes a little bit longer to get an MRI, and also the MRI is not necessarily going to tell you about the penumbra. Interpreting the CT perfusion, the point is to figure out the size of the core infarct and the extent of the ischemic penumbra to figure out who would most likely benefit from reperfusion. The three main things we want to look at on our CT perfusions are the mean transit time, the cerebral blood flow, and the cerebral blood volume. The core of the infarct is going to go on to encephalomalacia regardless of the therapy, and that's going to be defined as having a prolonged mean transit time, a decreased cerebral blood flow, and a decreased cerebral blood volume. The ischemic penumbra, however, is usually surrounding the core infarct. The mean transit time will be prolonged, but the cerebral blood volume should be normal to near normal, and that's going to help you figure out which part is the core infarct and which part is the penumbra. That's called mismatch. As a convention for all the following cases, the cerebral blood flow will be on the far left, the cerebral blood volume will be in the middle, and the mean transit time will be on the far right. Here we have a patient who has dizziness and balance issues. They got TPA at the outside hospital. We can see our cerebral blood flow, our cerebral blood volume, and our mean transit time. We can see that our CBF is decreased in that left cerebellar hemisphere. Our mean transit time is increased, but our cerebral blood volume is pretty normal. On the CTA, we can see that there is a small thrombus of the basilar artery in the region of the left superior cerebellar artery. On MR, we can see that there were infarcts, and that is abnormal perfusion from that superior cerebellar clot. Here's an 80-year-old with altered mental status. Now on the non-contrast CT, we see a dense right ICA and MCA. With stroke windows, we can see that we're losing definition in the sulci of the right cerebral hemisphere, and the gray-white differentiation is not as sharp as on the perfusion study shows abnormal cerebral blood flow, volume, and mean transit time involving the right MCA and ACA territories. But if we look more closely, we can see that the cerebral blood volume in the left ACA territory is preserved, whereas the cerebral blood flow is decreased and the mean transit time is increased. When we look at the angiogram, we can see that there is no enhancement of that dense ICA. We can also see that there's no enhancement in the right M1 segment or that right A1 segment. Now, why might that have caused the perfusion abnormality we saw? On the MR, we can see that there's infarct in the right MCA and ACA territories, as well as a portion of the left ACA territory. That's because the patient had a dominant right A1 segment that supplied the bilateral ACAs, which caused the perfusion abnormalities and infarcts. This is another case. In this perfusion, we can see that there is decreased cerebral blood flow, relatively preserved cerebral blood volume, and increased mean transit time in the right frontal lobe. And that is a right ACA penumbra. On this perfusion study, we can see that there is decreased cerebral blood flow involving a large portion of the right cerebral hemisphere, somewhat preserved cerebral blood volume, and increased mean transit time. That is a right MCA penumbra. This patient had recent subarachnoid hemorrhage, and now they have altered mental status. We can see that our cerebral blood flow is decreased, particularly in the junction of the right middle and anterior cerebral artery territories, where there is a focal area of decreased cerebral blood volume. In that right anterior cerebral artery territory, we can see that the mean transit time is increased between the right MCA and ACA territories and right MCA and PCA territories. That's going to be from vasospasm. Here's a perfusion study in a patient who has slurred speech and right-sided weakness. Again, use the history that you are provided with. We can see that there is decreased cerebral blood flow in the deep white matter of the left cerebral hemisphere. We can see that the cerebral blood volume is decreased to a lesser extent, and we can see that the mean transit time is increased in that left MCA territory. That's an area of infarct with surrounding penumbra. Recap. If the cerebral blood flow and mean transit time are abnormal, but the cerebral blood volume is normal, this is a mismatched area, and that is penumbra. If all three are abnormal, then this is a matched area, and that is infarct.